Next, coming to typhoid. Typhoid is usually caused by a species known as by gram-negative bacteria known as Salmonella, and so usually it causes in humans. It usually causes enteric fever, which is an acute infection. It is usually a foodborne and waterborne disease because of the contaminate intake of the contaminated food. It result in enteric fever, which is an acute infection. It could result in typhoid fever or paratyphoid fever. And the species which causes this typhoid fever are known as Salmonella typhi, and the species causing paratyphoid fever are the Salmonella paratyphi. So usually they are the gram-negative bacteria which show filamentous flagellae around the organism. There's a picture which shows the filamentous flagellae which are present around the bacilli. So coming to the epidemiology, usually we see most commonly typhoid fever occurring in India, and children are most commonly infected because of the improper hygienic conditions. And the disease rate, it usually is started decreasing as the countries are being developing because of the proper hygiene and cleanliness which is being utilized, and the improved sanitation and the proper provision of antibiotics for readily for the treatment which is being observed immediately. So the death rate, that is the morbidity and the mortality rate, have been decreased to this typhoid fever as countries have started growing up, developing. So coming to the death rate, how it has been decreased from 1990 is, in 1990 usually they have observed that 1,81,000 deaths have been included because of this typhoid fever. And next, followed by that, in 2010 there were 27 million cases which have been reported. Amongst them, few have been treated properly. In 2013 it was, the death rate from 1990 has been reduced to almost 1,61,000 deaths. And now presently the risk of death, it is usually reduced when the patient in 25, it is reduced in 25% of cases without treatment, and it is reduced to 1 to 4% with treatment. So this is the epidemiology of typhoid fever, or the because of the enteric fever. Coming to the pathogenesis, how usually the typhoid fever occurs. When the food or water which is being contaminated with the typhoid bacillus is being intaken, then initially there is a period of asymptomatic period which is known as incubation period for about 2 weeks is being observed. That is, there are no symptoms which can be observed clinically. But rather later, as these bacilli start invading and proliferating, and the most prone area for these tissues to for these organisms to proliferate is the lymphoid follicles and the Peyer's patches. That is, Peyer's patches are the lymphoid tissue which is present within the wall of the small intestine. So these are the areas which are being more prone for the bacilli to grow, and where they invade and proliferate. Once they start invading and proliferating within these areas, they reach the bloodstream through these. As lymphatic starts draining, these bacilla invade the bloodstream, and then they start showing its effect by the release of certain toxins from these bacteria, and start showing bacteremia, that is the symptoms of temperature and rose spots and certain other fever, weight loss, loss of appetite. These are certain systematic symptoms which are being shown by the patient who has been infected with typhoid bacillus. So this is a picture which shows rose spots on the abdomen of the patient infected with typhoid fever due to the bacterial action of the Salmonella typhi. Coming to the other symptomatic symptoms, that is, we see there's a swelling of the patient, increasing fever, that is a stepladder fashion of fever, that is a rising temperature. Along with that, we see headache, vomiting, malaria, coated tongue because of the improper removal or unclean hygiene, and abdominal pain. Hepatosplenomegaly can be seen, along with that myalgia, that is unexplained weakness, and diarrhea, constipation are also being seen in a patient infected with Salmonella typhi species. Coming to the other areas, as the area are being involved, there's been particularly a term when the intestinal lymphoid tissue, that is along with the Peyer's tissue, Peyer's patch, other areas, then it is known as typhoid intestinal lesions. When it involves the mesenteric lymph nodes, that is the lymph nodes of the intestine, that is it is known as hemorrhagic lymphadenitis. When the liver is involved, it is known as foci of parenchymal necrosis. When it involves the gallbladder, it is known as typhoid cholecystitis. When spleen is involved, it is known as splenic reactive hyperplasia. And when kidneys are involved, it is known as nephritis. And when abdominal muscles are involved, it is known as Zenker's degeneration. and in joints, arthritis, bones, osteitis, and when brain part meninges is involved, it is known as meningitis, and in testicular area, then it is known as orchitis. So these are certain lesions when they are involving particular area caused by Salmonella typhi species. Coming to the demonstrating aids, that is a diagnostic aid in Salmonella typhi, is a Widal's test, which is an immunological reaction. It is a reaction usually used to observe the presence of the antibodies which have been developed against these foreign antigens of typhoid bacilli in the infected host individual. So this step. Viral's test is based on a principle that when an antigen, that is a reactive viral antigen, is being introduced into the host who has been infected, human who is being infected with Salmonella typhi, we see that the patients, suppose the patient is infected, there are the presence of antibodies which are being seen, and these antibodies, when they react with the viral test reagent, they start showing clumping, that is agglutination of the, because of the reaction of the antigen and the antibody to these bacilli species. So this reacts in an antigen, and this is the principle behind the viral test. So there's a Okay, this can be done either in a test tube or either within a slide, where with a certain where we see that in the first picture that the viral tissue reagent is being pipette drop is being placed, along with that there is an isotonic saline, and the patient serum is being placed in the circles where the viral tissue reagent is being introduced into these drops, and along with that the other antigens are the O antigen, H antigen, H antigen, and the RH antigen. They are being introduced, and once this is being introduced, it should be waited for 1 minute, and it should be mixed with a separate sticks individual on the individual circles, and then it is being rocked gently. The slide is being rocked gently for 1 minute, and after that it is, should be observed for clumping. When if there's presence of clumping or agglutination or formation of clots within this dilute, then it is known that they are antibodies, and the patient is said to be infected with the Salmonella typhi, and he has antibodies for the Salmonella typhi. Usually we see it takes from the time of infection, the patient is being exposed to this bacilli, to the time of infection to be established, it might take 1 to 3 weeks of time. So this is what is Widal's test. Coming to the microscopic features, usually we see hyperemia, that there's increase in the blood supply. This can be microscopically observed with the increased size of the blood vessels. Other than that, we also see edema, that is escape of the intercellular fluid, which appears as a watery or diluted material within a microscopic slide. Other than that, we also see cellular proliferation, which shows presence of erythrophagocytosis, that are the erythrocytes and the phagocytes, along with that lymphocytes and plasma cells, so which can be observed under a microscope. And we see also presence of neutropenia, decrease in the number of the neutrophil count, which is usually seen in infections. There is one of the finding which is seen in a total WBC count, that there's decrease in the number of neutrophils. And lymphocytosis can be seen, that is an increase in the lymphocyte count, is also one of the cardinal sign of Salmonella typhi. So the culture being used for this tubercle typhoid species is McConkey agar. When the patient's sputum or otherwise when the discharge is being cultured, then we see that there's formation in the picture, which can be seen that there's formation of colonies within this McConkey agar, which is a culture media which is most commonly used for the Salmonella typhi species. So this what completes the typhoid. Coming to syphilis. Syphilis, it is usually a venereal disease which is being caused by a group of species known as spirochetes, among them Treponema pallidum, which usually causes this sexually transmitted disease. So there's no toxin, any kind of toxin which is being produced by this Treponema pallidum. Rather, the pathogenesis is again because of the immune system, as we have seen in tuberculosis. Coming to the epidemiology, usually in 2015, it has been identified that Cuba, the first country in the world, it has been identified to eliminate the transmission of syphilis from mother to child. So, recent advances have been progressing, so they have been identified to prevent this transmission by the transplacental route of syphilis development in a developing child. And in 2013, it has been observed that 3,15,000 people have been infected with syphilis. In 2010, there were 1,13,000 deaths which have been because of the syphilis. And in 1990, they have been observed that 2 lakhs to thousands 2,000 members have been infected with this syphilis. So, because of the decreasing availability of penicillin in 1940s, the rates of infection have increased. So, as there have been recent advances being introduced by an experimental studies in certain surveys, the syphilis has started reducing in the countries. From the mode of transmission, how it syphilis can be transmitted to a patient is mainly because since it's a sexually transmitted disease, that is, it's a venereal disease. It is most commonly because of the sexual intercourse. Other than that, it is because of the intimate person-to-person contact. That is, when there is a close contact between the patient who's been already infected with syphilis, there are chances for a normal healthy individual to also develop. Other than that, during the transfusion, such as blood transfusion or organ transplantation, there can also be one of the mode for the transmission of syphilis from person to person. Then materno-fetal transformation, that is from the mother to the fetus, is also one of the route for the program transmission of syphilis. Coming to the types of syphilis, it is usually congenital syphilis or otherwise acquired syphilis. Among the congenital syphilis, we see the usually congenital. It means syphilis developing by birth, usually at the age of 16 weeks of gestation period. Usually the fetus gets exposed to the maternal spirochetemia and starts showing its effect. And since it's in the gestation period, as the fetal starts developing, it starts also showing the syphilis bacilli also showing its effect. And rather, because of an improper developed host immune system by the fetus, there are certain symptoms which can be seen among these patients. We see that the patient, the fetus, by birth only starts comes with a gives birth with a saddle shaped nose deformity. Other than that, we also see Hutchinson's teeth, that is incisors, which usually, we see that the patient starts developing the teeth which are microdontia, that is smaller in size than the normal, with showing increased spacing amongst the teeth within the jaw, and there's also notching within the incisors as a teeth start growing. We can observe that there's notching. If there's a presence of natal or neonatal teeth, also we see this notching of the Hutchinson's teeth. So there's one of the primary feature which can be seen in congenital syphilis. Other than that, mucocutaneous lesions, that is the lesions, syphilitic lesions, or the mucus patches which can be seen involving the mucus areas, that is it could be in the oral cavity most commonly which can be seen, and otherwise in the cutaneous skin lesions. The bone lesions can also be seen, interstitial keratitis, formation of keratitis within the interstitium, and diffuse fibrosis in the liver is also one of the area. The others is the interstitial fibrosis of lungs, and the patient in severe cases where the syphilitic lesions have very much been established because of the improper host immune system development by the maternal system, the fetus might be born dead. So it could result in a born dead birth of an infected syphilitic condition. We see that there is premature with macerated skin, syphilitic epiphysitis, that is developing long flat bones. They show inflammation. This is known as syphilitic epiphysitis. And other than that, we see there's enlargement of the spleen and liver. So these are the clinical features which are being observed in a congenital syphilis condition. So there's a picture showing Hutchinson's teeth with the notching of the central incisors, and they are being widely spaced. And next comes the snuffles and the radiating fissures in a congenital conditions. Coming to the acquired syphilis, usually we see there are three stages of the primary acquired syphilis, which would be because of the sexual intercourse or otherwise because of the intimate contact from the infected person. So these syphilis are being divided into three stages depending upon the period after which the lesions start appear and the type of lesions. They are being classified into primary syphilis, secondary syphilis, and tertiary syphilis. Coming to the primary syphilis, usually we see that the patient initially affected with primary syphilis, it usually the patient starts developing these clinical signs and symptoms usually starts being shown 2 to 4 weeks after the exposure to the infection. It develops as a cankre, and this cankre usually is seen as a central, it is as a papule, that is as a central circumscribed area which is raised above the skin, and this papule it starts progressing into an ulceration. That is, we see that centrally in the picture we see that the central ulceration, and peripherally we see the induration, that is this hard growth outgrowth, and then this is followed by regional lymphadenitis, that the regional lymph node starts showing inflammation. And then primary syphilis we see that there's no scar, that they heal normally, they do not show scarring. As in cases of healing, usually we see primary healing and secondary healing. Primary healing generally heal because since the lesion is small in size, whereas secondary healings heal with the scar formation and fibrous tissue or granulation formation because of the large lesion. So since primary syphilis is a cankre, is a circumscribed lesion, we see a healing without any scarring. Coming to the oral manifestations in primary syphilis, we see a solitary ulcer, and most commonly seen areas is the lip or the tongue, and we see a single ulcer which can be seen in these areas. Other than the areas which is being followed are the other than the limbs and the lips and the tongue, followed areas, next common areas which are being affected, they are the pharynx and the tonsils, but these are least commonly affected areas when compared to the lip and the tongue in primary syphilis. So the ulceration is the most common feature which we see in syphilis. Among this, the ulceration, it appears as a deep red purple ulceration with a proper base, and this base appears brown in color, and it has an irregular raised border with induration. And there's also associated cervical lymphadenopathy in cases of ulcers or the oral manifestations in primary syphilis. Coming to the secondary syphilis, if the primary syphilis is not being inadequately treated and being neglected, then it might develop into mucocutaneous lesions. And this mucocutaneous lesions, that is the development of further progressing of the primary lesions, might result in painless lymphadenopathy. That is the regional lymph nodes in the area wherever the syphilis, primary syphilis has been progressing into secondary syphilis. It could be the cervical lymphadenopathy or a regional lymphadenopathy. The lymph node starts enlarging in size, and this can be observed 2 to 3 months after exposure from the infection. So in secondary syphilis, we see that there's positive antibodies test when when the patient serum or the patient is being suggested for certain laboratory diagnostic tests, then there shows positive antibodies for this syphilitic organisms. And the secondary syphilis is most commonly known as of highly infectious stages. That is, it might be highly contaminated. Highly contaminated. The mucocutaneous lesions are said to be highly contaminated on contact with a normal individual. And the spirochetes can be easily demonstrable when the smears of these lesions are being taken and observed under microscope. Coming to the macropapillary lesions, they are usually of macular syphilites, papillary syphilites, mucous patches, news maligna, and nodules. These are certain macular lesions which most commonly being observed in a syphilis. So the macular syphilites, they are the lesions which are seen in the secondary syphilis. That these lesions, they manifest characteristically as macules, which will be flat, and as they progress they might get raised, and they might show a change in a color, and most commonly involved areas is a palate and the gingiva. Coming to the papillary syphilites, these syphilites, they form papules which are raised usually above the normal level of the skin, and most commonly seen areas is the gingiva and the palate. And among them, we see that the papules, they might, if the lesion persists and starts progressing, it might develop into ulceration with a raised border, and this ulceration, it could be turn into a shallow ulceration. Mucous patches, which is the most commonly observed finding in the secondary syphilis. In these patients, we see that these mucous patches, it might include any area in the oral cavity most commonly, and rarely it might include in the palate also. We see that they are even its involvement in the commissures, that is at the angles of the lips, where they might result in formation of split papules. And if it involves if these mucous patches are being observed in any patient, and if a proper diagnosis is supposed to be given, or if the patient is supposed to be suspected for syphilis, then we have to look for a bilateral involvement. That is, in syphilis we see bilateral involvement of these mucous patches. They are usually small, they might develop as small patches which could be a macule or papule, but rather they might progress into ulceration. Coming to Lues maligna, these are the lesions which are seen, which usually arise as de novo. They might arise as general patches, or otherwise patches which might fuse to form and result in a formation of snail track ulceration, and this is known as Lues maligna. Nodules, the nodules usually arise as a they might arise as a raised nodules which might measure very mild in diameter, but these nodules, if they are not being treated at a proper time, they might progress into ulceration with the raised border. So the common feature among these maculopapular lesions which progresses, there's formation of shallow ulcers or crateriform ulcers which can be seen in these conditions, and these are most infected conditions. So these are pictures which show the presence of secondary syphilis. Coming to the tertiary syphilis, usually we see that the tertiary syphilis occurs after a period of latency. That is when the bacilli undergoes a period of latency, that it does not show any effect, but rather it starts. After 3 years of exposure, it starts showing its activation, and then it starts showing the clinical signs and symptoms. But compared to the primary and secondary syphilis, it is a less infective stage, and the organisms can be observed even in this stage on culture. Usually, since it's a tertiary syphilis, it is of two types. It could be lesions are known as syphilitic gumma. They are usually depressions which are being formed. These lesions, they appear as shallow depressions or otherwise shallow raised ulcers, which usually progress to form, and they start eroding the bone. Also, they appear such they are such an exaggerated lesions, where we see when there's palatal involvement in such syphilitic gumma, we see that there's palatal perforation which might result in an oroantral fistula, and this is usually healed by secondary healing with formation of fibrosis, and an unhealed lesion might also progress into, it might give an appearance of an cancerous lesion. In radiologically, we can see a proper radiolucency in cases of syphilitic gumma, and diffuse lesions, when the lesion starts spreading to another areas, they result in large maculopapular lesions or snail track ulcerations, and it is known as diffuse lesions. And other than that, this diffuse lesions these bacilli may also spread to cardiovascular system or the central nervous system. When it involves a cardiovascular system, it is most commonly starts affecting the thoracic aorta, and this aorta might show aortic syphilitic aortitis. That is, there will be inflammation, widening of this aorta. It might also cause a aortic aneurysm. These are certain conditions which are caused when the tertiary syphilis involves a cardiovascular system. When it involves a neural system, that is a nervous system, when it most commonly involves a meninges as well as a dura and spinal cord. These are the certain diffuse lesions in case of syphilis. So these are the pictures which can be seen, how a patient is being showing a syphilitic gumma, where the bones are being eroded completely because of the progression of the bacillus being affecting on the tissues of the host. Coming to the demonstration, usually on electron microscopy, we observe this bacilli as we observe Treponema palladium as a filamentous bacilli. Usually, this is the first picture showing the electron microscopy, and the silver impregnation technique of this Treponema palladium, these parakeet species, appears as a filamentous species. They are the gram-negative bacilli. Coming to the diagnostic aids, usually there are certain tests which are being done to identify the presence of antibodies to these syphilitic bacteria in the host system. So they are being they are being classified into two types, that is a treponemal serological test and the non-treponemal serological test. Coming to the treponemal serological test, they are the tests which usually observe the presence of antibodies to these bacilli, these syphilitic organisms. Among them, it is the FTABS test, that is a fluorescent treponemal antibody test, where it observes the presence of antibodies to these in an infected patients, where the where the patient serum is being placed in a slide with a depression, where these antibodies are being exposed to the antigens which is being observed from the rabbit which is being infected with syphilis, and for the binding of this antigen to the antibody and forming a clumping, or the in introducing a fluorescent antibody and showing its fluorescence helps in the observing, gives a positive result that the patient is infected to syphilis. Next, coming to the other agglutination test, that is a microheme agglutination test, where the patient's erythrocytes are being taken and they are being placed in a placed in a well in a slide. These erythrocytes are being placed also being placed. Uh, Erythrocytes from the patients are being exposed to the antigens which are being observed from derived from an experimental animal such as rabbit or a mouse, and these agglutination, that is a heme agglutination, showing presence of the clumping of this erythrocytes to this antigen, shows that the patient is infected to syphilis. The other type is serodia, that is a Treponema palladium test, heme agglutination test, as well as Treponema palladium. Next, coming to the non-treponemal serological test, that is the reactive reagent protective reactive test, and the venereal disease research association test. So the Treponema palladium heme agglutination test, which is a serodia test, that is which tries to observe the presence of antibodies to this syphilitic parakeet species in the blood. So this is one of the tests which tries to identify the antibodies which are being produced by the host immune system against this parakeet species. Coming to the non-treponemal serological tests, they are these tests which are called as non-treponemal because they do not identify the specific antibodies which are being produced, but rather they identify the host effect of the host individual who has been infected with syphilis, that is they identify the immunoglobulins G, M and A for the antibodies against the bacilli. So a rapid protein reagent, which is a reactive protein reagent, it is a test which means reagent which does not identify the antibodies which are being actually produced by the host immune system, but rather it identifies the cells which have tried to kill the bacilli, but during the killing of this immune mediated cells, immune cells, the host immune cells such as the lymphocytes which produce certain immunoglobulins, these are being tried to be identified by the reactive protein reagent test. So this is what seen in non-treponemal serological test. Coming to venereal disease research laboratory test, which is the most common test which is used as a confirmatory test for syphilis. Usually there is also a non-serological test since it does not identify the antibodies which are being produced for the bacilli, but rather it observes the response of the patient to the therapy which is being given by being controlling the central nervous system and properly observing the central nervous system and its activity, that tries to observe that whether the patient is being responding to this to the therapy which is being given against this syphilis. So these are the certain diagnostic aids which can be seen. So there's a picture. These are the picture which is being seen. That is a VDRL test, which consists of a sheet of wells where it shows that the reaction between the serum of the patient as well as the reactive reagent. And then comes the treponema heme agglutination test, which shows the agglutination of the patient serum with that of the reagent which is being used in the test. Then coming to the rapid point of care syphilis test, where the finger is being pricked, and this diagnostic cassette which starts showing the presence of the test bands which shows that the patient is reactive to syphilis or no. So this completes syphilis.